Welcome to the webinar. Welcome everyone, and thank you for joining us for this evening's webinar. It is a pleasure to be here with you tonight, and just wanted to go over a couple of easy tips to help you to use the Zoom function. Most of you are probably even better at that than I am at this point in time, but just in case, we do have a Q&A, and if you look at your screen, there's a Q&A button, but we won't be using that because I am the only moderator here and I'm teaching, so I'm going to ask you to use the chat function. So just check to see if you can see the chat. If you look at your screen, you can see at the top, or depending on where you have the little memo button, select the chat button and just put that on the side of your slides so you can chat, because we are very conversational this evening. We'll be sharing some great ideas. And if you have questions, you can also post them on the chat. I will ask that you do mute yourself at this time, as I'm going to pretty much teach straight through. And at the end, we'll open up some time for you to have a chat. But in the meanwhile, you can type that all up. Tonight's webinar is 2 hours. And EduScience is an approved provider of continuing education by the National Certification Board for Therapeutic Massage and Bodywork. So you get 2 credit hours. To get those credit hours, please stand by at the end of the program and make sure you complete the survey. There's about a 10-question survey at the end, and do tell us how you feel about it. Any other information or questions about that, or if you miss it somehow, you can certainly email me. I am Dr. Teresa Schmidt, and the email is edusize@edusize.com or info@edusize.com. And I posted those in the chat. You also have received my contact information in your email, so feel free anytime, give me a call or a shout by email, and I'll be happy to provide you resources, answer questions, whatever it is you need that I can help you with. So thanks for your time. Going through the chat there, just wanted to see who's out there tonight. So if you would just take a moment, give us your first name, your profession, and let us know, where are you coming from? So I'm up here in the beautiful Granite State of New Hampshire, and I'm Dr. Teresa Schmidt. I've been a physical therapist for over 35 years now. So yes, getting old and loving it. Still finding that much of this work is fabulous to help people to get back to a great quality of life, to help them smile and feel good and moving again. And I know that you are looking forward to doing the same thing, helping people get back in action and enjoying their lives. Less trigger points will help to make that happen. So I used to be from New York. Actually had a practice in New York for over 25 years, and I do miss my New York buddies, but love being up here in New Hampshire. Of course, you see this beautiful background here. I wish I was in Florida, but we've been having single digits and below zero lately, so it's been a little bit of a challenge, but we're keeping warm, giving patients that ice massage, right, when you touch them. So we're seeing out there, we got Lorraine, great, from Seacliff, wonderful, nice North Shore area. Norma from New Jersey. Oh, massage therapist and PTA, fantastic. I'm also a massage therapist for about 30 years or so. And a nice combo to put that PT and massage together. So really can serve quite a few people. So hello there to Jersey. And Carlene from Empower Wellness in, how do we say that? Mukwanago, Wisconsin. Love it, love it. I've been out to Wisconsin. What a beautiful state. You have a gorgeous capital, by the way, in Madison. What a beautiful, beautiful building and wonderful people. So thanks for coming on with us. And OT, which is wonderful. Now, I did mention that this course is approved for credits by the NCBTMB. So you might want to check with your own boards to see about the credits. At the end of these slides, you'll see
you don't have a keyboard to chat.
Please go ahead and mute your situation out there. I think someone there is chatting. Just to put yourself
because
right
other
there.
people is writing where they
chat. Yeah, just go ahead and
from.
There you go. So I think I did that for you. So this way you don't have to keep on letting us know your personal business there. So great. So just check with your individual boards. You'll see the course description, the learning objectives, references, all the things the boards are looking for, or at the end of the slides. And if you need any additional information, just reach right out and I'll get back to you to help. So I see we also have Terry from Lake Placid. Massage therapist, fantastic. Love that Mirror Lake and fabulous skiing up there in Lake Placid. So I bet you're having some great skiers come up into your office now. And I see Carlene, close enough. Okay, good. And Matt Anderson. Matt, also another from Wisconsin. Most awesome. Love working with you. Thank you so much for joining us. And we're going to go ahead and proceed right into our trigger point webinar. Again, guys, feel free at any time to just pipe right in on that chat, ask questions, provide suggestions, whatever it is that you like to do. And then we have Lynn. Hey, Lynn, fabulous physical therapist from New Hampshire, PT for 30 years. Again, this great experience that you people have, share that with us. Give us some of your enlightenment, because tonight's webinar is really about being a mastermind group. And that is many minds make light work, right? Many hands make light work. So Napoleon Hill, who wrote the book Think and Grow Rich, said, no two minds ever come together without thereby creating a third, invisible, intangible force, which may be likened to a third mind, the mastermind. And that's what we are. We're bringing all of our fabulous experience together and sharing that. So don't be bashful. Feel free to go ahead and share on that chat. So mastermind is basically an alliance. And I invite you, coordinate with other clinicians, create an alliance of your own. I know with the COVID situation, so many people have felt a bit more isolated, not going to the usual conferences, hands-on workshops, all those beautiful meetings that we so enjoy. So I invite you, at least connect as much as you can. And we're getting past this. I know we'll definitely get past this. We're very resilient and we have a great future to look forward to. So get together with other clinicians, share your work, make your own mastermind groups, or join up with us. The coordination of knowledge and effort of two or more people who work toward a definitive purpose in the spirit of harmony. And that's exactly what we're looking to do. So gather your group together. So you want to build your success and support each other, share your clinical experiences, share those case reports. What did you do to help that person with the chronic pain? Maybe you came to, feeling like you hit a wall and couldn't do any more with that person. Oh, she's got fibromyalgia and she's been in 20 accidents and now she came in and her back is out and no matter what I do, she still hurts. What do I do with her? Pose these questions to your group. Brainstorm it. That's the value of the mastermind. And then, of course, if you do this with the group on a regular basis, as we did, we had a myofascial study group in New York for over 25 years, and it was great. Whoever went to the latest seminar would come in and share the latest they learned. And of course, the best part, saving the copays. We all treated one another. So it's really a wonderful, wonderful thing. One of the things I most miss about being back in the Big Apple. So peer accountability, when you get together with the group and there's an expectation that you have something else to offer. So there's a give and take, and you're accountable to be constantly improving and learning, because that's what builds us in life so we could grow and contribute. So you want to share some insights, share your intelligence, your tips tonight with us. There's no wrong answers. There can be some silly answers, and I'm sure I can come up with a few of those for you. So for our discussion, I'd like to just start by asking you to share your greatest challenge when you're dealing with people who have those nasty trigger points. So go ahead on the chat and type in for us, what is your greatest challenge when addressing trigger points? Well, I'll start, since I need to give you some time to type. I found that people who have had multiple accidents and many trigger points, such as people with fibromyalgia, are really a challenge to work with, because you start to work on trigger points, say in their neck or back. Now they're worried about their hip or their shoulder. It's always moving around and changing, isn't it? So it's almost like you're chasing that trigger point down. Where's the next one? And that's a classic thing. People with fibromyalgia have trigger points, typically more than 18 out of 24 standardized points on the body. So how much can you chase those points? Well, I hope I can offer you some really great work tonight with a little smattering of manual therapies that make it easy on you and easy on your hands to work with these people and help to make a difference, many times even during the same visit. So let's see what you came up with. Okay, Carlene, saving your thumbs. Yes, indeed. We don't want to be all thumbs, do we? We want to use thumbs, fingers, knuckles, elbows even, forearms. Many times we like to use tools as well. I love to use cupping tools. Different types of massage instruments can be helpful to save your hands. Just remember, when using tools, of course, You need to learn to feel through the tools, to extend your proprioceptive sensitivity, your palpation sensitivity through that instrument into the patient. So it's always best to try those tools on yourself first, try working with a fellow clinician first, and get that feedback that's so very valuable. Is it too deep? It's not deep enough. And that's always a big question. It's never deep enough for some people, and it's never light enough for others. Where is that sweet spot in between? That's about building your sensitivity and working with people with experience, getting that valuable feedback. So like, see what we said, Norma's saying some pokes at trigger points tend to be more guarded, and you need to break that barrier down first. Well, tonight, I invite you to explore something that we call positional release, where we break that barrier down by helping people to be more comfortable and decreasing the sensitivity of the trigger points without having to mash and stress ourselves by putting so much pressure on them. So it's a little refreshing change. It's called an indirect technique, and that's exactly something we're going to explore. So I know there's a couple more folks out there. If you could just share your best tip for managing trigger points. Do you have a go-to modality that you like to use or go-to intervention? Go ahead and post that on the chat, and I'm going to go ahead and move along, and we can watch that chat as we go. Please make like you're in a real classroom setting with people. These are your colleagues, these are your friends, your peers. Go ahead and share with them. So we're going to start with the basics. Trigger points can be found all over the body. Where do you begin? That's the question of the hour. I tend to look to see what is most impairing someone's function. What's the biggest, baddest trigger point of them all? Like we mentioned earlier, some people with the fibromyalgia are one walking trigger point, right? But where do you start? Try to assess and see what's most impairing their function. It's easiest just to start by asking your client, what hurts the most? What gets in your way of the everyday things that you need to do and love to do? Tell me about that. How does that affect you? And I like to explore and assess and analyze that area, and I'll start by addressing that first. So interesting stuff. So trigger points, what are they? I've actually heard some people even lately online saying, oh, trigger points don't exist. I said, really? Let me get my hands on you. I'll find some, guaranteed. So they're defined by Doctors Travell and Simons, who wrote, of course, you are familiar with the trigger point manuals. If not, look them up. There's trigger point charts, trigger point manuals, and they got some of this ball rolling years ago by noting where trigger points are typically found in the muscles and the fascia, and giving us different positions to stretch and engage them. So they defined it as those hypersensitive areas within a muscle or its associated fascia, and what happens when you press on them. People yell, they scream, they move away from you. It's like, hey. So those trigger points might be spontaneously painful, like, oh, it hurts here, and I didn't even touch it, but it hurts. So that's an active trigger point. They could be painful upon compression. Maybe you check the other side and the person didn't know that he hurt over here, and you started poking around. He's like, ow, ow, that hurts. That's a latent trigger point. Patient didn't know it was there, but when you started poking or working on it, it reared its ugly head. So that's a latent trigger point. It's just a little quiescent as opposed to being active. So we have active and latent trigger points. There are many other types of trigger points. We're going to keep it basic here. So these points can often refer pain to other areas. And many times they are directly related to acupuncture points, neurovascular points, neurolymphatic points as well. And there's over an 80% correlation with the acupuncture points and trigger points. What's the difference between a trigger point and a tender point? That's interesting. Well, a tender point, you hit a point, say, oh, it's sore right there. It's just sore or hypersensitive. It doesn't refer pain anywhere. The muscle doesn't move. The person doesn't, back away from you. So a tender point can be just sensitive or sore, but a trigger point will typically have muscle contraction associated with it. And when you poke at it or strum across it, the person might twitch or jump. And that's typical. That's telling you that they have an abnormal, sensitive, myotatic stretch reflex. Remember the stretch reflex? Reflex are? So that muscle spindle is hypersensitive to stretch. And when you go poking at it, it contracts because the alpha motor neuron is saying, hey, protect yourself, protect yourself. That's part of that guarding response. So these also typically, trigger points that is, refer pain to other areas. For a tender point, it's tender right here, and that's all it is. But a trigger point, you push on that, and there may be referred pain to other areas. Sometimes it looks confusing to a practitioner. You need to remember it's not always within the same dermatome. Trigger points are for pain through the fascia, which connects everything in the body. And there are, specific patterns of referral. You can look at trigger point charts for that, or Travell and Simons' ancient trigger point books that are still really valuable resources for you. So typically there's persistent contraction where the person's just holding. Do they even know they're holding sometimes? How many times have you gone up to a patient, you see, they're holding their shoulder up. Put your shoulder down. Oh, it's not up. Put it down. And I put them in the mirror and like, oh yeah, it is up. I didn't realize I'm holding it. So this persistence, they get used to it, sometimes don't even realize they're holding that tension. And when you go and strum your fingers over the muscle, you can palpate. It's like taut, ropey cords, like you could play guitar in that thing. So we call those taut bands. You can document that and put all this information in your note. I know how you all love to write documentation and describe to people how wonderful you did a job on a patient, but we do need to document. So this helps you. Patient had an active trigger point in the right upper trapezius. It limited their range of motion. Maybe it limited left lateral flexion, right? It may be referred pain up into their head or even their eye. A patient's walking around, oh, I feel like I got a brain tumor. I'm getting pain up in my eye. No, that's coming from the trigger points in your neck and occiput. So it's important to show them that you can reproduce that. And even more important, if you could help to reduce that painful sensitivity that's getting in the way of their everyday living. The other curious thing about trigger points is they could refer pain, and they could also affect the autonomic nervous system. You have sympathetic innervation to multiple areas, particularly to circulation. And these areas could have reduction of circulation. They could be cold and clammy as a result of too much sympathetic phenomena related to those trigger points. On an extreme, chronic regional pain complex, regional pain syndrome is very, very common. So I'm seeing Teresa is saying the connection seems like I'm in and out. Is anyone else having this issue? It looks clear to me on my side, but certainly let me know if anyone could just respond that you hear me, yes, or you don't hear me well, no. And I do have a fast connection. Okay, so great connection. So you might want to check your own connection there. Thank you for letting me know. And so what's a trigger point, right? Muscle tension results in muscle pain about prolonged contraction of the intrafusal muscle fibers. So those are our reflex arcs, right? It occurs due to activation of the gamma motor neurons and increased sympathetic activity. So that autonomic system gets overloaded. And sometimes you could even see the hair standing up in those areas. Sometimes you see goosebumps in those areas. And in the case of something like complex regional pain syndrome, reflex sympathetic dystrophy, you can actually have people whose circulation is so impaired that the skin becomes very shiny, bluish, swollen. There's a great deal of edema associated with that. And in a long-term stage, if that sympathetic nervous system continues to be hyperactive in that area, it starts to actually leach the calcium, the minerals out of the bones, and people become osteoporotic, osteopenic. So that's something, as you may know, complex regional pain syndrome can go on for months to years. So it's important that we get in there and try to affect those reflexes, which is something that these techniques are talking about today may be helpful for. I've had good results when using these in my practice, and hopefully you will too. Okay, and oh yeah, Norma, thank you. Leather-like, yes, they're very leather-like along these taut bands and trigger points. Thank you. So trigger points have been studied. Anyone ever see a trigger point? They've been studied on EMGs, electromyograms. So a physical therapist named Barbara Headley did quite a bit of publication on this, and we're seeing more of this today, where there shows active contraction of the muscle on EMGs, electromyograms. And when a muscle contracts, what happens? Calcium goes into the T-tubules of the muscle, right? And that allows that actin and myosin to overlap, right? The cross links of actin and myosin. As that calcium builds up in the T-tubules, the muscle contracts. And if the muscle is ready to relax, there is an active process of pumping the calcium out of the T-tubules that occurs physiologically. And that process requires oxygen. Without oxygen, you can't get the calcium out of the T-tubules. So what happens? You get tetanic contraction. It just persists. So there's just a selective shortening of the sarcomeres within the muscle. You ever notice in a trigger point, typically, there's just certain bands of the muscle that seem to be affected. It's not usually the whole muscle that's knotted up, is it? But you can feel those tight bands. So that selective shortening of sarcomeres. We need to help that muscle to relax so that we can clear that abnormal reflex that's causing the trigger point. So we learned quite a bit about this using EMGs. So interesting, also EMGs are shown to be in areas of trigger points that are not just too much muscle activity, but sometimes an area of too little activity. It's been documented that areas of trigger points, although more rare, they can be areas of electrical silence on an EMG. When I first read that, I was thinking, oh, electrical silence, the muscles relaxing. How wonderful to kick back and relax once in a while, right? Who doesn't want to kick up their feet on their desk and take it easy a little bit? Well, if you did that and stayed in one position and stopped moving and just continued relaxing, what would happen? Circulation gets cut off. We need to move. Movement is life. So too much contraction or too little contraction both can create trigger points. So what Norm is saying, like an underloaded muscle. Yes, muscles that are too long or too short are both going to be weak. So too much facilitation, too much inhibition. In other words, those abnormal reflexes are what we are addressing when we're dealing with trigger points. So to document them, who can't wait to brag about all the good work that you did? Of course, where is it? Okay, patient had an active trigger point in the left extensor origin, wrist and finger extensor origin, say lateral epicondyle. Maybe we call it tennis elbow, lateral epicondylitis. Okay, so we know where it is. Referred pain into the dorsal hand on palpation. How bad did it hurt from 0 to 10? Oh, that was a 6 out of 10. Goes in my note, pain scale 6 out of 10. Did the patient twitch or jump? Positive twitch sign. You might have just felt it twitching a little bit under your fingers, or positive jump sign. Some people jump right off the table, don't they? So that really tells you they're hypersensitive. And of course, you palpate, you're masters of palpation. So those ropey taut bands, we put in the note, positive taut bands in the, say, extensor digitorum communis or the supinator or whatever area that you palpate. So it's nice to be remembering your anatomy so you can be precise about your documentation. Because you want to come back later and see, did it actually make a difference? Which of course, it'd be wonderful if it did. So question for you, how did you learn to assess trigger points? Now I see we have a wonderful mix of PTs, OTs, assistants, massage therapists, wonderful, because there's different backgrounds in our education. But we all learn a bit about trigger points. So just in brief, if you could put on the chat, what did you learn? How did you learn to assess? Did they tell you to put a certain amount of pressure on the area? How much pressure do you use to test a trigger point? So go ahead and put that on the chat. Do you think you use 1 ounce, 5 pounds, 2 pounds, a lot of pressure? You don't know? Go ahead and post that and let us know. I'll give you a minute to put that on the chat because it is questionable. American College of Rheumatology has suggested that we use 4 kilograms of pressure to test tender points or trigger points. So I'm thinking, do the math if you're converting English to metric and back and forth. So 4 kilograms, 2.2 pounds per kilogram. That's about 10 pounds. How many of your patients, think of your elders, think of maybe some of your more fragile patients, maybe some of your younger folks. How are they going to tolerate you putting 10 pounds on them when you're testing the trigger points? Well, I can tell you from 35 years of experience, I have quite a few patients who would not like 10 pounds of pressure, but that's something I found to be relatively consistent from the American College of Rheumatology. We have some from the peanut gallery out there. Teresa, sink in slowly. Yes, slowly and gradually is awesome. Norm is saying, I think for me, it's intuitive for a pound of pressure depending on the client. And that's a big thing today. I was recently speaking with another therapist or two, and I said, how much pressure do you use? They said, you really need to address each individual patient's needs. What do you have, a frail elderly person with thin skin who's on blood thinners, who bruises easily, and maybe their muscles are also somewhat atrophied? So what about that college football player with the huge muscles? What about those professional dancers I worked with for years? Some of those people, you look at them on a stage, they look so graceful and you feel like, oh, I could massage them easily. Well, their bodies are like tree trunks. I've worked with them, try massaging and working them, kill your hands, let me tell you, if you try to go deep. So it's about managing your pressure for each individual patient. And I like to meet and match the resistance I sense in a tissue. So practice really helps you. Lorraine says you find it difficult to determine the amount of pressure based on pounds. It's more intuitive. Yeah, and it does depend on each client. So they have instruments called algometers is one, an algometer. And pressure point threshold, PPT, is what we typically call what we're measuring when it comes to how much pressure do you put on someone before you are eliciting pain. And that's called the pressure pain threshold, or PPT. So using a pressure point, you could use the PPT and get an algometer, or some people call it a dolorimeter, dolor meaning pain, dolorimeter, measuring exactly how many pascals of pressure that you're putting, or how many pounds of pressure per square inch or per square centimeter that you're placing on the tissue. So you could get a dolorimeter or an algometer, pressure algometer, to measure that. So, but most of us go intuitively. Just know that there is research on that, and you can actually measure it. So to document those trigger points, remember too, that trigger point, because it's causing the muscle to shorten, may limit range of motion, and it may also alter posture, alter proprioception. How many people have seen patients come in where, the head's tilted to one side? I had a lady who was a waitress, and her head was always tilted to one side. And I asked her, "Where do you carry your trays?" She said, "Yeah, I carry the trays on that side." Okay, there you go. So that she didn't realize she had her head tilted, but because she was so used to it, and that's what felt normal to her, to have that stress. When we got her aligned, she said, "This doesn't feel comfortable." I said, "When you do your exercise and you finish your therapy, it'll feel normal again." It also weakens the muscle. Sometimes the muscle that holds a trigger point is weak. Sometimes the antagonist is weak. So if you think about trigger points in the hip flexor, that is firing away. It's reciprocally inhibiting the hip extensor. So sometimes addressing that hip flexor trigger point can actually increase strength in the glutes. You know that gluteal amnesia that so many people have? Yeah, look back there and see, hello, we forgot how to contract well. That could be a cause of some of the weakness. So it's an easy thing to address. And of course, lack of exercise can also be something to address, but this works faster. So you could use a manual muscle tester. I use a Nicholas manual muscle tester, a handheld dynamometer, to measure strength before and after doing some of this work. Right there, the same treatment time in the clinic. So I could show the patient, "Oh, look, your strength came up by 5 pounds because we got rid of that nasty trigger point that you had there." So what if the range of motion is limited because the trigger point is tight? Say that person had tennis elbow. You think, oh, tennis elbow might be limiting what? You think tennis elbow would limit flexion or extension of the wrist in terms of passive motion or stretch? Tennis elbow is what muscles, flexors or extensors? Let's see that on the chat. Remember your anatomy. Yeah, they're extensors of the wrist and fingers. So they may weaken, especially reciprocally weaken, the grip. They can also be weak themselves because they're sore and strained or tired. So it could affect both sides. So thank you, Norma, for your answer on that. Functional outcome tests are really important. I'm not going to go over all of these, but I will give you a link where you could find them. I know different professions will use different tests, but these are fairly universal. Neck and back disability index. If you have a patient with back pain, you could use the Oswestry back disability index, a Roland Morris disability questionnaire. And these are questionnaires, self-reported outcome questionnaires. You give a patient the form or the computer with the form on it, and they answer the questions, and you could get a score. Oh, look, she's 60% disabled by this problem, according to the NDI, neck disability index. And maybe next visit you check again. Oh, look, now she's only 40% disabled by this problem. So we had a 20% improvement. Things like functional gait assessment, how does their ambulation change? There's all kinds of upper and lower extremity functional indices, like the lower extremity functional scale, upper extremity functional scale. Pain scale that we mentioned from 0 to 10, how bad does it hurt? Global outcomes can be measured, and these all have scores. So you can look these up online, and I'll tell you where to look. Gait assessments are very functional, things like the timed up and go test. Hey, get up and go from the chair, walk 10 feet, come back. I clocked you. How long did it take to do that? Before and after an intervention. 2-minute walk test. How fast do they walk in 2 minutes? How far do they walk in 2 minutes, right? 6-minute walk test. So how many meters per minute does someone walk? 6-minute walk test. So you're probably not likely to do all of those in your practice because you might not have 6 minutes to do it. but you can time an activity and see if that activity changes. How much endurance do they have? What about ergonomic exams and sports capability exams? So those are all helpful. Pain inventories, like a McGill pain inventory. So not to bore you with all these outcomes here, because you really want to get to some of our nice videos, but if you go to this website here, SRA Lab, it used to be called Rehab Measures Database, Rehab Measures. And now it changed. I guess somebody gave them some money, and now they called it the Shirley Ryan Abilities Lab, sralab.org. So if you're looking for functional outcome measures to show that you made a difference, the patient has progressed, or consequently, maybe they regressed for some reason, something got worse, you can use the functional outcomes here, and it gives all kinds of psychometrics and batteries of information on, is the test reliable, is it valid, what kind of patient populations is the test appropriate for, and so on and so forth. So anyone using that Rehab Measures database, SRA Lab, and if you know other great databases, would you please post them in the chat? I know one I love is Physiopedia.com, Physiopedia, and I don't get any kickbacks for sharing any of these things, just mentioning them to you. They're great resources. So Physiopedia has lots of information there as well. What is the most common trigger points you see? So go ahead and put that in the chat. I know no snoozing out there. I need to see a little bit on the chat. Where's the most common trigger points in your patients? Well, I would say the most common I've encountered, upper traps. There you go. What's the most researched? I've read hundreds and hundreds of studies. Upper traps. Yes, glutes very common. QL, that quadratus lumborum, hidden low back. Levator, right? Everybody's shrugging up their shoulders with all the stress and tension. Supraspinatus, right? Just deep to that upper trap. And next to that levator, the scapula. So yeah, you got it. You guys are pretty much on the same page. So first in contraindications, we're covering a lot of body parts and techniques. So there's just general contraindication. If movement's contraindicated for some reason, or touch is contraindicated for some reason, obviously we're not going to be working on those people. If it's a condition you don't know about, simply get medical clearance. There are different backgrounds here. Maybe you're a massage therapist, an OT, PT, so you have different examination and assessment skills. So I always just use the general saying, you don't know, you don't go, right? Find out first. I had a lady who came in with her daughter who was a therapist, and she was limping and with her little rolling walker, and her daughter was actually helping her move the walker, even though it was on wheels, because she was having that much soreness. Although she liked to dress up, so she had like fabulous makeup and hair and high heels, even though she couldn't walk very well. It was an interesting thing to see when she came in. But her trigger point in her hip flexor was so bad, so very bad. And I palpated both hips to see what happened. And she said, oh yeah, the last physical therapist office put me on some really heavy equipment, and they told me I had osteoporosis. This woman was like 80 something years old. So they had me do all these exercises, and they put her on a machine for the adductors of the thighs, adducting against heavy resistance. And she complained, this hurts. And they said, oh, you're weak. You need to work it out. You need to build up your bones and your muscles. So she strained her hip flexors pretty bad, but it was much worse on one side than the other. And I asked her, I said, well, didn't you do the machine on both sides simultaneously? She said, yes, indeed. Well, when I palpated, I felt in her right hip, felt like bubble wrap popping. Her tissue was so fibrotic and scarred down. I said, what happened to your hip? She's like, oh, nothing. I never hurt the hip. Well, I found out from her daughter, she had radiation therapy on that hip because of cancer in the lymph nodes. But she didn't think that was considered an injury. So she said, oh, I never injured my hip before. So I said, well, I don't know if this pain is there because you actually hurt yourself on a machine, or because your cancer came back, or something else. We need you to see your physician first, find out what's going on. And she went to get a PET scan actually, and came back. We learned it was indeed a hip strain. So I felt comfortable to go ahead and treat. So even if you think that you know it all and I'm just going to go ahead and help this person right away, sometimes you have to wait and get medical clearance. So has anyone ever seen a trigger point? Raise your hand if you've ever actually seen one. Well, I had a great time. I happened to go to the Rehab Summit. Thanks with Matt there, who was at the Rehab Summit as well. Wonderful, wonderful conference. So many fabulous topics and speakers. And they had some exhibitors there who had ultrasound machines, a high resolution ultrasound, high frequency ultrasound machines that are used to actually visualize the trigger points. You can see them on these imaging studies, and they look just like what they feel like under your hands. They're nodular, and they're areas of thick collagen, too much scar tissue that's laid down. Now, I didn't yet get permission to show you the picture of them, but look up online because you could see this yourself. Fascia Research Congress. Fascia Research Congress has phenomenal pictures and information about all things fascial. And I've both taught at the Fascia Congress and attended a few of them. Wonderful experience. But there's lots of ultrasonic pictures of trigger points there as well, and great research. So Sikdar said that, using ultrasound imaging to visualize active and latent trigger points, they did a physical exam. They did that pressure algometry where they measure, how much pressure can someone tolerate before they have pain. And using grayscale ultrasound, vibration sonoelastography, and Doppler ultrasound, what did they find? They said these myofascial trigger points, MTRPs they call, appear as focal hypoechoic regions, so they don't echo as well as other areas on two-dimensional ultrasound. So there's local changes in what we call tissue echogenicity, the ability of that ultrasound to bounce back and give us a picture, and also focal regions of reduced vibration amplitude, indicating a localized stiff nodule. So you can actually see these stiff nodules that are elliptical in shape, and they found that there's really no differences in ultrasound with active trigger points or latent trigger points, ones that we said that people can feel and they know they have them versus ones that patients don't sense that they have them until you poke at them. They also found that there's resistance in the circulation, so there's poor circulation in that area as well. So we know that that circulatory issue can also contribute pain because that limits oxygen supply. So this is very cool stuff that we know these trigger points are real. We can take pictures of them on imaging studies. Now, how are trigger points managed? How many of you are seeing more and more patients getting trigger point injections? Raise your hand and let us know. I've seen that come up over the last, say, 10 years because docs are paid really well to do injections, but they might not be paying so well to do hands-on therapy, which is unfortunate. And I've tried that. I've had some issues, and I tried trigger point injections years ago. It didn't help me personally, but I know other people and patients that it did help tremendously. So it's really, I guess, up to the individual patient and doctor to decide what's best. So I see Lynn and Matt both agree, yes, some on a consistent schedule of every 3 months. So imagine people going for trigger point injections regularly. And I like to think if someone's going back for treatment of whatever kind and something's only getting better temporarily, are we really serving them as best we can? I know some things we can't heal, and I understand that, but I find if the patient, I tell a patient the day one when they come in, look, if I don't see some changes within 2 or 3 visits, I'm outpatient based, so I'm not dealing with people who are in a skilled nursing facility in a coma. That's very different. But the everyday outpatient person, or if you're working inpatient with people who have like orthopedic, neurologic issues and trigger points, you should be able to see some change within a couple of visits. Otherwise, I tell people if you're not seeing a change in 2 or 3 visits, hey, I need to either examine you more carefully, maybe refer you out to find out what's going on. Maybe there's something I'm missing, try a different intervention. I need to question you more about what you're doing at home or not doing, because that could make a big difference as well. So we're looking today at manual methods of dealing with trigger points. I also use other things like hypnosis. I'm a certified hypnotherapist, and I find it's very, very helpful to alter pain. I've used it for myself. I've used it for my patients. It's very, very helpful. The usual physical agents, modalities, heat, cold, TENS, electrotherapy, ultrasound, all helpful. Interesting, I just read quite a few studies, updates on trigger points treatment using ultrasound and electrotherapy. Great studies. Yet the insurance companies often will say they're not covering it because there's no research. So go figure, right? We need to send them those studies. There's, of course, ergonomics. We were just mentioning, what if the trigger point just keeps coming back? Well, if it just keeps coming back, obviously we're missing something. Maybe that person's going back to work and lifting things the wrong way. Maybe that person never learned how to breathe properly, so the trigger points keep coming back in their accessory respiratory muscles. Maybe they're getting too stressed and the trigger point keeps coming back for that reason, because we didn't help them understand how to manage the stress or refer them to get some education in that regard. So there's reasons things keep coming back, and that's something for us to look. So I'm seeing Norma, dry needling, yes, very helpful. Very helpful. Acupuncture can also be very helpful. Posture-driven trigger points, how we hold ourselves. How many people today, and especially since COVID hit, are just constantly on the phone, typing away on the computer, staying in one position too long, right? Looking at a screen instead of moving. So we know that many of these things make these trigger points come on back again and again. So methods that we have that we're going to cover tonight, ischemic compression, which is great. Who wants to squash that trigger point, right? Myofascial release, one of my favorite techniques. Positional release, which is also called strain counter strain. It's a traditional Dr. Jones technique that's been modified and adapted by new practitioners. Massage technique called orthobionomy. I'm not covering that specifically, but just putting the name out there. They use positional release or strain counter strain type of interventions like what you'll see this evening in combination with massage type interventions. And that's also great work. So people keep changing the names of some of these things. And just when you think you've got some good research on like strain counter strain, they change the name to positional release. You got to start all over again. Interesting now that the Fascia Research Congress had noted that there's tremendous interest in the nomenclature that we use to describe manual therapy, as well as to describe fascia and what we do in all different versions of fascial release, myofascial release, fascial mobilization, fascia therapy, Rolfing. There's all kinds of different terms for pretty much the same stuff. So muscle energy, which is the osteopathic term for what PTs often call proprioceptive neuromuscular facilitation. And that's just using reflexes to trick the body into doing what we want it to do. In this case, we want the trigger points to relax. So people would go about their lives having a good time. Today, we're just going to focus on a simple version of that in our short 2 hours together, and that's post-isometric relaxation, or PIR, some people call it. And of course, others have come up with new names for that so they can sell you a new seminar. And I can tell you flat out, I didn't invent any of this stuff. I learned it from fabulous teachers along the way over the years, and it's great to always give those folks credit. So you'll see there's a wonderful bibliography at the end if you want to look up any of the references or resources where this comes from. It's not the Schmidt technique, but how we put things together becomes our own, isn't it? Create your own way of sequencing the techniques, your own handling, and that's what makes your practice special. That's the art of what we do. So there's also cold spray and stretch. I'm just going to touch on that a little bit because there's plenty of that information for another day. Okay, so ischemic compression. Who can't wait to squash the trigger point? I do. That's actually the last thing I personally like when I go for a massage. I'm just interested because I have a collection of trigger points, and someone just to go in and start mashing them, not for me. I ain't paying for that, as they say back in New York where I come from, ain't paying for that stuff, but it can be helpful. And if used correctly, and if used in a way that's not forceful, it can be very helpful. So ischemic compression, that's basically positive pressure. Some of you have things like, I'll just pull up one of these here a minute. Positive pressure is what we are typically doing in the body with things like massage, right? We're pushing into the body, positive pressure. What about cupping tools? Remember cupping? Negative pressure cupping tools? That's negative pressure. That's pulling the tissue away from the body. Cupping. We're not covering cupping tonight, but I have some great seminars on that as well, if that interests you. So positive pressure application to those trigger points. And of course, I have interviewed so many therapists asking them, how much pressure do you use? Boy, do I get a whole variety of answers. So it can be variably painful, persistent manual pressure against the tissue barrier. And that barrier concept is important. The barrier is the point of tissue resistance to movement. Does the tissue yield readily to your movement and gradually as you take up the slack? Or do you come to an abrupt stop? So you go through the soft tissue, the skin, subcutaneous tissue, and then all of a sudden, there's a tight spot that feels like it doesn't yield to my resistance. That's a barrier, an end of the motion. So how does this work? Well, there's many different ways that ischemic compression is theorized to work. One is based on the gate control theory. You might remember the Melzack and Wall gate control theory of pain, that pain travels up from the peripheral nerves into the brain, into the central nervous system, enters the spinal cord, and typically goes up, say, like the spinal thalamic tract to the brain, goes through the thalamus, and then it gets processed throughout wherever it heads in the brain, and then we interpret that pain. Many people interpret pain differently. I get an athlete on the table that loves to have an elbow dug into a hamstring, and I'll get another person on the table that has softer muscles, a little less in shape, and they're not a fan of an elbow back in their hamstrings. But they're all following that same C nerve fiber for pain. The C nerve fibers are the small nerve fibers that carry pain. When they get up there to the spinothalamic tract, it decides where that pain is going to be interpreted in the brain. Now, if we activate the thick nerve fibers, the A fibers that carry more pressure sensation, you can supersede those incoming messages that are heading to the brain and block them to a degree. And that's what we call the gate control theory. Putting on pressure will inhibit some of those pain signals at the thalamic level. And that's saying opening the gate to interpret the pain versus closing the gate to the pain. So we call it the gate control theory. It's kind of like saying, well, I moved to New Hampshire, but I still have a New York accent. So maybe you don't care for my New York accent and you're like, oh, this is too loud. I can't hear it. I can't hear it. So what do? Turn up your radio or TV really loud and drown me out, right? That's like the C fibers or the accent you don't want to hear or the noise you don't want to hear. The TV's like the A fibers. You turn up the volume to block out the other input, right? So that just gives you an idea of the gate control. So I'd like to ask you guys, what do you say to a client before you begin using compression? What do you tell them? Do you give them any information about, well, I'm going to start squashing this tight spot with my elbow or my fingertip or my massage tool? And is there anything that you describe to them that they should expect? I find sometimes people just go right through their treatment and don't say a word about what they're going to do, and others will give you every detail or nuance about what they're going to do. So I suggest if you're using ischemic compression to alert the client or the patient, we'll just say the word client, that you're going to be applying some pressure and it should be tolerable. We want applying some pressure to test to see how sore that point is, and can they give you a score from 0 to 10. 10 is the worst pain you could imagine, 0 is no pain, where along that range. So when you're testing, you could use one thumb, fingers, whatever you like to use, but if you're going to be holding, you want to stack your thumbs, thumb over thumb. And it's very, very helpful to line up your body weight behind you. Now, typically we're not using that much force here, but when you're doing this often on multiple patients, you want to use a thumb over thumb or fingers over fingers if you're going to be holding something, even if it's not with a lot of force, but for a long period of time, because you'll be getting sore otherwise. So just a little suggestion. Thank you, Norma. I say that I'll be going a little deeper, and a little discomfort is okay, but no sharp pain. Nice. I like that, because you're letting them know, hey, sometimes trigger points have sharp pain and you just touched them lightly and didn't realize the patient jumped clear off the table. Other times you go deeper and they're barely reacting. You can't always predict what's happening. So gradual is key. And then how much compression pressure do you apply? We were talking about that earlier, so we're going to move right past that. So saving your hands is critical. We all work with our hands, and after 35 years of thinking, sometimes I want to do things more gently, of course. My very first job at the Manhattan VA Veterans Administration as a PT, 1985. Yes, I'm old. And they called me the bone crusher because I thought everybody had to be mobilized and manipulated. And it was a very strong emphasis in my PT school back in the day. And we had quite a bit of stiff people with joint replacements and so on. So, wow, right away when I was told I was the bone crusher, I'm like, okay, I need to do something about that. I need to lighten up and also save my hands. So they did me quite a favor by calling me the bone crusher. So I learned that on day 2. So you can use all different things to compress a trigger point, elbows, knuckles, fingertips, etc. But you want to make sure you keep your joints neutral. I see people like hyperextending their thumbs, hyperextending their fingers, bending their wrist and poking like this. If your wrist is in a position where you're compressing some of that median nerve, not good. Keep your wrist neutral. So use some instruments for the ischemic compression, but use your fingers or an algometer to test how much pressure to use, because instruments can be irritable to the body, and it's very hard for you to feel adequately through the instrument unless you have lots of practice. So sink gradually into the trigger point. Do not force it. I've had lots of patients complain to me about, oh yeah, when they went someplace else and somebody just dug in really hard and they told them they had to stop. And I've seen patients come in with black and blues. Even when I was in massage school, I had one lady come in, which is very helpful. All of her acupuncture points were black and blue, because the last therapist just thought they had to push really hard. It made it easy for me to learn the acupuncture points, but it wasn't so great for that patient. So your fingertips have exquisite sensitivity. You've got Pacinian corpuscles and Ruffini nerve endings and all kinds of cool stuff in there to sense what's happening in the body and feel for the resistance in the tissues. And that takes practice. If you're a newbie, I think most of us here are not newbies in the field, but if you are a newbie, work with another clinician and start to practice to sense different layers in the body. And myofascial courses can help you do that. Massage and palpation courses can help you to do that. So again, don't force. I like to tell patients, look, if the pain is more than a 5 out of 10, I need to back off. Where did I get the 5 out of 10? Well, it occurred to me over the years to just ask people, what level is the pain? How is it? And most people could tolerate things that were below a 5, just personal clinical experience. Interesting, I was writing a course on clinical practice guidelines for frozen shoulder, and I came across some studies in the physical therapy journal, and they were saying the same thing, keeping the pain below a 5 out of 10. So I'm like, oh, I finally found somewhere in the literature where someone else came up with this 5 out of 10 thing. So even some people can't relate to numbers. They can't give you a number. Maybe they speak Russian and you speak Spanish, and they don't speak English. And who knows? I'm from New York City, so many times we encounter people who don't speak our language fluently. So I need to sense what's happening in that tissue if they can't communicate. And you bet you need practice to do that. If that tissue is tensing up under your hands, it's too much. If that client is moving away from you, oh, it's definitely too much. And of course, if they're making noise and crying out, or you see their eyes dilating, it's too much. So look at the patients, look, listen, and feel. Even if you're working through a drape, and I know many times massage, we have in NPT and OT, we have to drape appropriately. You can't always look through the drape, but you can feel through the drape. And if you have like a blanket on, I would just put a thin cotton sheet over that area and feel through the cotton sheet so the patient is comfortable and draped. But you should be able to feel through that region. And if the area is that questionable, you should be able to inspect the skin. So you might need to ask that person's permission or have another person in the room, like chaperone, with that patient's permission to examine an area or refer to a medical professional who can do that examination for you. So it's important. Now here's a study I read. There's a reason that this is all crossed off here. The Cash App study was talking about, okay, to treat the trigger points, this is an example of one of many studies I found in literature. And they said, gradually apply increasing pressure, just like we all discussed before. And they said, use enough force to elicit moderate tolerable pain. They called moderate tolerable pain 7 to 10 on a scale of 0 to 10, if 10 is the worst pain you can imagine. Now, if you look at some of these scales, and when I did my doctoral research, which I published, I looked at the numeric pain rating scale, the visual analog scale about pain. And usually they have pictures of faces with some of them. One of the studies actually described how people would physically react. And pain of 10 out of 10, they can't talk, they can't move, they can't walk, they can't anything. They can barely breathe. So, if you would ever decide to put pain that high a level at a patient, I'm sorry, but I think someone will be calling your malpractice insurance very quickly. So I don't agree with that, but I wanted to just post this up there to see what it is. They said to hold that compression for 20 or 30 seconds. I don't know where they got the 20 or 30 seconds from until the pain reduces to a 3 out of 4. And then they want to increase it again to a 7 out of 10. I don't think so, but this stuff is out here and that's a little scary to me. So I like to put pressure on that area just so that they can appreciate that there's some sensitivity there and slowly wait for that to soften and release. Keep that pain below 5 out of 10. Match and meet the resistance that you sense in the patient's trigger point. Meet the resistance you feel in their body. So that's really a myofascial concept, that you don't exceed their resistance. If you exceed that resistance, you go past that point at which their body does not yield to your pressure, you're going to get a reaction. And if you don't, you're probably missing it. It's something to be aware of. Or maybe they're not neurologically intact, in which case you need to be exquisitely careful. So how much pressure? No definitive answer. I have not seen studies that say, oh, you should absolutely use so much pressure to test or treat a trigger point. So as you said here in this webinar, we gauge it based on the patient's response. We gauge it based on the patient's physical condition. Everyone is different. Very different for the person on the blood thinners who's elderly in the nursing home versus someone who's a professional dancer that I saw that's built like a tree and they're healthy. But maybe that person is taking non-steroidal anti-inflammatories for a week. Now their blood is thinner and they might bruise more easily. So that same person that last week could tolerate deeper pressure, for some reason this week, maybe they're bruising more easily because of the medication they're on. So just be aware if these things change with people. Always find out where people are at before you treat them. So match the resistance, avoid bruising, and of course, stop and release. If they complain, they withdraw, they move away from you. You're seeing their eyes are dilating. That's a sympathetic response. If they're tightening up in response to what you're doing with your intervention, contracting, guarding, that means you need to back off. And I've been for a lot of massages over the years. I'm a massage therapist. I'm a huge fan of massage. And I've had quite a few people just start drilling and digging in or yanking on me and saying, oh, you need this. I'm like, no, you need to stop. It's very important that people know when to say stop. And some patients don't understand that. They think, oh, the doctor's always right. Oh, maybe this is going to be better for me, so I should just let them hurt me. There's all kinds of people out there. So it's up to us to sense the limits and to understand how tissue responds by feeling. Practice, practice, practice. So, okay, I'm off the soapbox. Any comments or questions on that? All right. So use your thumb or fingertip. I recommend thumbs or fingertips at first because you're not going to go too heavy and you have much more sensitivity to palpate. Feel for that nodular tissue. Often it feels like almost like a piece of soap underneath the tissue. It's going to move. Watch also if they have areas of lymph nodes. Your anatomy where you're working. Is it a lymph node that's feeling that way? Is it a fatty cyst, a lipoma? So these things are going to be more in the superficial tissue, in the skin, just in the skin, subcutaneous tissue, as opposed to in the muscle. And the muscle will typically have the taut bands and the twitch and that referred pain associated with it. So slowly compress, assess the tension, going to hold that. A little trick I discovered just by doing it and from learning myofascial work, if it hurts to just go straight on the trigger point, address the trigger point from its aspect, its lateral or medial aspect. So in this case, if there's taut bands in the forearm, and I said, oh, look, I could play guitar on that. Well, there's a trigger point right there. Instead of drilling directly into the taut band or the trigger point, go to the side of it, maybe the lateral aspect or the medial aspect. So you're on the edge between the taut bands, as opposed to right on the string or between the strings. That's the fascial plane where one layer of fascia meets another. And those fascicles of muscles need to glide past each other. Obviously, they don't glide as much as I'm showing you with my hands, but you get the idea. They get inflamed and stuck together, and the glide is reduced, especially if they're still contracting all the time. So getting in that fascial plane, the space between the taut bands, and applying a gentle compression there, kind of like sneaking up on it. I find that that indirect approach is much more tolerable for people, much less sore and sensitive, and I still get a great result. Some fascial therapists call that muscle play when we stretch a muscle at a right angle to the fibers, to the taut fibers. But with ischemic compression, you could use the same thing. So muscle play, ischemic compression, very, very helpful to do. So any interesting patient reactions that you've had when you used ischemic compression? Has anyone used ischemic compression and would like to share your reaction? Love to hear it. I'm going to move on, but feel free to type away in there and share with us a little bit. So we got through our first hour. We're going to move right along. Some studies. This is a randomized clinical trial. People had shoulder trigger points. They said, let's give me the muscle energy or ischemic compression. And we're going to measure their pain, their mobility 6 weeks after treatment. And they found out that muscle energy had a greater effect on range of motion. So people got more mobility out of muscle energy than ischemic compression. So interesting. Which one was more effective to reduce pain? Well, ischemic compression was better for reducing pain, but muscle energy was better for improving range of motion. So different strokes for different folks. Excuse me. So for iliotibial band, how many people just love to have their iliotibial band, IT band drilled into? Like nobody. Yet we have people rolling on foam rollers, torturing themselves. So they can be very hypersensitive. This is a time where you could feel that iliotibial band along the side of the leg. Come from it from the posterior aspect. And I'll just use 2 thumbs to take up the slack and hold. So almost like you're doing a little anterior glide of the band over the underlying tissue, as opposed to coming directly at it laterally and right on the side of that muscle. There's also interesting acupuncture points along the iliotibial band that have to do with emotion, which are called gallbladder points. And they could be very very irritable in people. So I find that, again, more of a sideways approach to the trigger point instead of a direct approach. An indirect approach helps. Hold it till it melts. I don't worry about, do I hold it 15 seconds, 30 seconds? Do I hold it 90 seconds? I hold it until it softens. And that's the key. Go by feel. Don't go by sitting counting 2 seconds, 5 seconds. Here's another study where they said, they took 40 people with neck pain. They said, let's do friction to one group, ischemic compression to the other. They measured the pressure pain threshold, 0 to 10, and they used exactly 2.5 kilograms per centimeter squared of pressure before and 2 minutes after the treatment. And they said both of them improved a lot and both of them improved just as much. So both worked, friction massage and ischemic compression. So how many people have those tight bands in the front of their shoulder and the pecs anterior deltoid, especially being so forward in their shoulders and slumped? So if you see here in the picture, and these are still pictures because most of these are still techniques, I'm taking my thumb, I am staying away from the brachial plexus, which is in the axilla, of course, but I'm just lifting and holding that taut band in the pecs and waiting for that to soften. So I'm lifting and holding. Now, if someone's very sensitive here, which many people are, especially the frozen shoulder folks, I'll just adduct and internally rotate the shoulder a little bit while I do it to take some of the tension off so it's not so direct. We're going to talk more about that positional release in a minute. How about in the hand? How many of you work with your hands so much you get those trigger points here and there, or people texting away all the time, endlessly? Same thing. I teach patients how to find their own point, feel which direction. If you push it in or out, up, down, which way around an imaginary clock do you push on that band that it feels better? Push on it, take up the slack and hold, wait for it to soften. So that's, again, the myofascial concept applied to ischemic compression. So what if someone's sore after or during the compression? What do you do? And while you're thinking about that, I'm just going to read anything here. So Carlene, well, I've nearly gotten backhanded. Wow, he almost got backhanded by a patient. Woo! Thankfully, he held himself back. This was after he said that nothing was wrong with him and he was only there because his wife made him. Oh, wow. I turned him into a believer by relieving his pain and he was eager to return. Well, congratulations. That is most awesome. Okay, a quick peek just at the fascia. I'm not going to show the whole video. You can see this on YouTube online, but just see, what does a fascia look like underneath? This is with permission. Dr. Greenberg.
To approach these mechanical phenomena, we looked at the theories of chaos, fractal distributions, and their relationships with traditional science. There were many avenues to explore, and their purely theoretical aspects and metaphysical conclusions were to be treated with caution. Since that time, several scientific articles have discussed the notion of tensegrity. This concept of tensegrity undoubtedly threw light on our understanding of how organs slide together. The Americans Buckminster Fuller, an architect, and Kenneth...
I'm going to stop there, but you could look that up online, just YouTube, Strolling Under the Skin, Dr. Green Berteau, fabulous physician. You met him at the Fascia Research Congress. Just wanted to show you how the tissue does slide and glide and the collagen moves. He looked at the tissues under an endoscope in live humans. Fascinating stuff to see. So that brings us into our myofascial release, and that's using a controlled force to the body tissues in a very precise direction. So it's all about the depth and direction. Can you access the level of tissue resistance? Can you access the level of restriction? Using your palpation and then taking up the slack and holding. Typically we hold until it softens, which in the fascial world is usually about 1.5 to 2 minutes. So it's basically a soft tissue mobilization. And that's to improve the circulation, break up collagen crosslinks in the tissue, which we call adhesions or cicatrix, breaking up the scar tissue, and of course that reduces pain and edema. So how do we do it? You have to find the restriction. What direction is the tissue stiff? So I'd recommend, imagine that tissue you're working on. You're going to start with the skin and, like peeling layers of an onion, gradually go into the deeper tissues, superficial, middle muscles, deeper muscles. What direction is it sticky? So placed by hands on the body, superior glide, inferior glide, medial glide, lateral glide, it's stiff going that way. Take up the slack and apply gentle pressure, so a strain to the tissue in the direction where it's stiff. engaging the barriers, a direct technique, engaging the barrier. The key with myofascial release is we're not sitting here counting to 15 or counting to 60. We're just waiting to feel that fascia soften, melt down, and lengthen under our hands. So that requires some practice to recognize when that actually happens. If you're paying attention to something else, or you have so much tension in your body, you can't appreciate the tension in the patient's body. So it's about waiting for that softening effect. And typically that means you're holding it. Clinically documented for years is usually around a minute and a half, 2 minutes. That holding still is called a still point. The body will alter its tension inside. The fascial tissue will actually melt down its ground substance. That's the softening you feel. Fibroblasts will secrete nitric oxide and open up the circulation to that area. And that's that warming effect. Things start to move. The tissue itself becomes more fluid and less viscous. So you want to feel that softening and lengthening. Perform 2 or 3 of these myofascial stretches in a given area and then move along. So you want to specify the direction of force. Which direction is the tissue stuck? You're going to engage the barrier using your hands or tools. You can then work by checking, does the tissue turn clockwise, counterclockwise also? So that's more of a shearing force. And you're just going to follow that as the tissue melts down barrier by barrier to detect that release. Take up the slack and hold, move to the next barrier. Now I have whole courses on this, so I'm just touching on this again to give you some ideas of what to use. So here, how about for skin rolling? Can also release trigger points. I'm sure many of you have done skin rolling. Typically when I teach this in my live workshops, people are like, oh, I haven't done that in years. Well, now the latest studies show using ultrasonic imaging, those trigger points do appear as dense areas of collagen. And they did studies where they took people that had back pain on one side and no back pain on the other side. Said, well, let's do some skin rolling and some compression to those areas. We're going to treat both sides of the back and see what happens before and after using our ultrasound imaging. And they found out that only the side of the back that had the myofascial restrictions and the trigger points reacted and changed on ultrasound with decreased tissue tension and less density of collagen, less dense scar tissue as a result. And this is only a couple of minutes of skin rolling and compression. So a lot of people look and say, oh, that's so superficial. How could that be doing anything? Well, we could see it on imaging. So it's definitely doing something. So some pictures of skin rolling for the back and the neck. I do this all over the body. Some area of the skin is very tight, like the shins. Other areas, like the lumbar area, typically a little bit looser, scapula a little bit looser. So I'll show you some skin rolling right here in the video. Tissue rolling is our second assessment technique, and that would be using a pincer grip, using the pads of the fingers. We're going to use a pill rolling type of motion, gliding the tissues with our thumbs and feeding the tissues up into our thumbs with our moving fingers. Now the tissues here glide nice and evenly. You should be able to see a good picking up of the skin. Test centrally over the back and then test over each of the paraspinals. And here we see nice free motion throughout. I generally work from superior to inferior, but no reason you can't start from the inferior and work superiorly. If someone is tight in the back and you start down low, you may find it's difficult to start at that point. If they're very tight, you may also find that alternating the tissue rolling is a nice way to gain access and a better purchase of the tissues, and also to start some of the releases of the tissues. If I find an area is restricted with the skin rolling, I may do 3, 4, even 5 skin rolls over that area to soften the tissues. So this is great because fingers are so reliable. I can always count on them, right? I hope you can too. So that just shows you skin rolling. Again, it can be done anywhere on the body. It's a great warm-up. It's a great way to get things moving and a great way to address those trigger points. So typically I'll roll 3, 4, 5 times over an area and see how they do. Circular friction is something that's really a modified version of massage. When I was in massage school, we did acupressure, aromatherapy. We use a lot of circular frictioning type strokes to address areas of the fascial planes. They call them tendinomuscle channels, the acupuncture meridians in the body, where one muscle layer meets another. So you could use your finger pads, your knuckles, your elbow. You're going to work in these fascial planes the spaces between those muscle layers. Sometimes when you get in there and you feel that crunchiness, it feels like bubble wrap popping. I call that fascial crepitus. I write it in my note that they have an area of fascial crepitus. So typically that's an area of too much tension, scarring, and go gently because that could also be an area full of trigger points. How many people have those tight trigger points in the quadratus lumborum or the erector muscles? You can do some circular friction hand over hand to save your hands, hand over hand. They're just small circular motions in that area. Now I'm making a big motion just to make it obvious that that's, could be clockwise, counterclockwise, but the motion itself is so tiny you barely see your fingers moving because you're in the fascial plane, that narrow area between two taut bands of muscle. You're in that space. So you need to really feel to get in between those tight guitar strings and little circles, circular friction. So great around the QL. I could use an elbow there. But if you look, I don't drill the tip of the olecranon into the tissue. I'm using here more the condyles. So the distal part of my humerus. I don't drill the tip of the olecranon in because that could make people really sore. And again, we're gently sinking in and gently sensing where the tissue tension is, matching that resistance to go deeper. What about circular frictioning all around that upper trap? If you just trace the scapula, the triangle bone of the scapula, you hit so many muscle attachments. Circular friction is great on the muscle attachments, the origin, the insertion, and the fascial planes. So circular friction, I might spend several minutes just doing a whole scapula tracing, so to speak. So the fascial planes are located in the same areas of the acupuncture channels. Interesting. And they discovered this also with ultrasound. Those interstitial connective tissue points were found not only on ultrasound, but on CAT scans, on MRIs, and virtual imaging. So there is a distinct biological anatomical basis for those acupuncture channels. So now circular friction, although we start light, it can be done deeply as well. So let patients know, hey, I'm stretching stuff that you haven't moved for a while. Sometimes it feels like you had a workout. You might be a little sore tomorrow, but it shouldn't really be bothering or interfering with you while you're doing your everyday activities. If it is, it's too much. As Norma said in the chat, she warns them that they might be a little sore post-treatment, but it should resolve within a day, and that's a typical outcome. Yes, thank you for sharing that. With the circular friction, I found don't really spend more than a half a minute on any one area. Tissue gets too hyperemic. Too much of a good thing is not so good either. So let patients know. I teach them how to do this on themselves. I teach them how to use ice afterwards. It's like when you give somebody new exercise. You're looking to get some muscular hypertrophy. You're looking to grow the muscle again. And we have to push it to do that, right? We have to give a certain load to the muscle. So everyone knows you could be sore the next day, sometimes for 2 days. So teach them how to use ice, teach them how to use liniments, whatever things they could do, their own circular friction very lightly. So here's a little video on that.
So we're making sure we're focusing insertion to origin or origin to insertion. We're circular frictioning the origin of the muscle, the insertion of the muscle, and all the nooks and crannies within the muscle. The spaces between the taut bands of tissue. So here we're doing some circular friction myofascial work. We're working in the fascial planes between those taut guitar strings of the hamstring. So she was digging. Show us where it was sore. Reproduce that for us. Okay, stop right there. So there we go. We got a jump.
See the jump?
If the patient's jumping because you hit a trigger point, you don't just drill into the trigger point. Trigger point's typically in the taut cord of muscle. You'll feel like a thick fiber of a guitar string. So instead of digging on that fiber, I'm going to move and work, say, lateral to that fiber with my circular frictions. I'm going to work medial to that fiber in the space that my fingers naturally sink into. The fascial plane's little spaces between the fibers. And you can work and strip up both sides of that taut cord. And if you come back, you'll find, oh, the trigger point's melted down. And that's one of the nice things about using this circular friction, whether it's, fingertips or knuckles, thumbs, elbows, will be very effective.
So that gives you a little clue there on some of this circular friction. And nice area to work around the thumb. And with ischemic compression, we were just holding a point. Here, we're actually working through. So you could try on yourself now with your hand, get your thenar remnants, probably work with your hand. You could use your fingertips, but feel where you come from the joint or from the CMC to the MP joint and feel some of those flexor pollicis brevis, abductor pollicis brevis. Can you feel the space between those two and make little tiny circular frictions? I could use a fingertip because this is a very fine area. Little tiny circular frictions. What if you used your thumb to do it? What if you were looking at, say, tennis elbow? Can you do little tiny circular frictions with your fingertips between the taut bands, working your way down? So start in lightly, sink, sink, sink. There's the resistance. And then start the little circular frictions. So it's different than transverse friction because you're in the fascial plane. The space is not rolling across the taut band. You're between them. So fingertips, knuckles, elbows. Again, you're taking up the slack, holding gently, waiting for that softening and moving on. Work an area, feel the soften, move it on. And if it's too much, move on. Don't go drilling. So myofascial release is many, many styles. This is just a little taste of it. Lots of courses on that. Do check out my website if you're interested in any of those courses, and many other people. Fascia Research Congress has some great work on myofascial work. So evidence, they find that microfiber injury as a result of overdoing it, stress and strain to the muscle is mitigated by massage and myofascial release. If they have induced muscle damage, they took a bunch of guys, said, okay, we're going to make you work out on an exercise machine as hard and fast as you can until you're so sore you can't do anymore. And they found out by checking their blood before and after, for the group that had massage and myofascial work after they were strained, they had reduced inflammatory mediators called cytokines. The other half of the group in this particular study had elevated inflammatory mediators who didn't get the massage. So we know it helps to reduce some of the inflammation. And the collagen density is also reduced by connective tissue massage. You can see the names of some of these studies here and find them in your bibliography. So has anyone used myofascial release? Any case report or information you'd like to share, or maybe your own personal experience with myofascial work? Like it, didn't like it, thought it was too light, thought it was too deep. Think it's fabulous. I think it's fabulous when it's used correctly. Very, very nice. So we're going to move on into some positional release. This is positional release. And remember, when you're doing some of this work, you are using your hands, so save your hands. And even if you totally strain your right hand, remember there's always one left. So just to keep you on your toes. And if you can't afford a hand transplant after you strain it, doing all that deep tissue work, you could always go to the second hand store. So keep you on your toes. Positional release, also one of my favorites because it saves your hands and you don't have to drill into the trigger point. So many times patients are thrilled. Someone asked earlier, what if my patient's too guarded and I can't do the ischemic compression or the myofascial release? Because maybe when they went to the doctor's office, they were drilling into them and they're like, now they're afraid to have anyone touch them. So strain counter strain, renamed positional release, uses a position of comfort to reduce the sensitivity of those trigger points. So we talked about those muscle spindle reflexes becoming hypersensitive. That's evidenced by trigger points. So that excessive muscle spindle excitement is measurable on EMGs. We see that the muscle's hyperactive. So it's prolonged contraction. What if you did this? Make a tight fist, open it up at the end of the webinar, and see how that works for you, right? No, don't really do that. But imagine if you did. It's like almost 45 minutes from now, you're going to be like trying to peel your fingers open because you get tired. Muscles use up oxygen. It's hard to undo it when they run out of oxygen. Okay, relaxation is an active process inside the muscle. So we need to restore that reflex back to its normal level of excitation, not so hypersensitive, but a normal level of excitation. And positional release or counter strain does exactly that. And we have the proof of that based on EMG studies. I have the best proof of that based on feeling what my patients can do right after the treatment. So how do you know that those reflexes are abnormal or facilitated, hypersensitive? ART. There's an abnormal posture or joint position, abnormal positioning, or for range of motion is limited. You can measure that, goniometer, flexibility test, and tissue tension is elevated. You know how to feel that. Palpate. They have trigger points. So ART tells you that there's abnormal facilitated reflexes. So a couple samples of studies for positional release. Here they said, well, let's do a positional release technique, positioning versus a placebo where we just pressed on the clavicles in 99 subjects who had trigger points in their masseter, masseter of the cheek, clenching, temporalis, and internal pterygoid muscles. And they were looking at the TMJ here. So their outcomes were how much can the person, open their mouth, and how much can they bite, the bite force. So they pre-treated for 1 minute, test, pre-treat, post-treat, and they said, let's just hold the trigger points for the TMJ for 5 minutes in that relaxation position, and found out that the person could open their jaw better and had higher bite force in the group that actually had the treatment as opposed to the placebo. So again, back to the most common trigger points at upper traps and levator, showing you those muscles here, upper traps here, and on the levator, scap is deep to the upper trap. This is actually, got the wrong picture in here. What are these here? Okay, levator. Okay. Scalenes are in the front. Levator is going for those posterior tubercles of the cervical spine down to that superior medial border of the scapula. So upper trap's on the surface, and then levator's underneath. Let's take a look at how to do it.
So it's easy to find in the middle, especially, of the upper trap muscle belly, there's often trigger points. I mean, who doesn't have a trigger point here, right? Any tension in any of these spots?
Right
there. And feel a few spots. Don't go just for the first one. Little tension here, too. There seems worse.
Yeah.
Okay. 0 to 10?
About 5.
Eddie, put your right hand on your belly. Just let it rest there. So I'll just reach over, grab his elbow, just go right up through the humerus, and I could palpate at the same time that I'm moving his shoulder, just using the humerus as a lever. And just let that kind of rest there. So you want him to relax. You might want to hold it in that shrug position. Any different here?
Yeah.
Any numbers?
Maybe a 2.
Maybe a 2. So not a 0 yet. Let's see maybe a little bit more elevation. Relax it. Any difference here?
Yeah, it's gone.
Gone. Okay. Now just watch. Are you comfy to stay like that? I don't have to be touching him for this to work. The pure point of strain counter strain is that the position is doing the work. And I could come back, and if you're good at your palpation, you could come back to the same point and know where you are. How's it now?
Good.
Good. So touching the patient is not part of the treatment per se. I like to have my hands on the patient because I can feel when that muscle's relaxing. Okay? I can also take this time to say, do a modality. If I'm working on his upper trap, I could put him in a counter strain position. Say you wanted to use some heat and electrotherapy. You could go ahead and have the hot pack and electrodes on and leave him in this position as long as he's comfortable. If the shoulder shrug was not enough, I could have added the other actions of the upper trapezius, which would be side bending to the same side, extension, and rotation away from the trigger point.
That gives you an idea of how to deal with some of the nastiest trigger point. Basically, do what the muscle does for a living, but do it passively. That upper traps does extension, side bending toward and rotation away from that side. So you position them passively. And if they can't extend, for example, then just side bend and rotate away. So you don't have to do all the motions of the muscle, but you want to take the strain off by shortening it passively and allowing that person to relax during the procedure. What about that tennis elbow? We were just mentioning that earlier. So extensor digitorum communis muscles, extensor carpi radialis, ulnaris, that combination of muscles all going to that lateral epicondyle. Remember the supinator attaches there as well, but it's really deep. So that attaches directly to the lateral epicondyle where all the rest of the extensors really just attach through a tendon. And there's the ulnaris as well. So just to give you a quick review of the anatomy, take a look at releasing tennis elbow, lateral epicondylitis. To find tender points here in the wrist, palpate from the lateral epicondyle, extensor carpi radialis, extensor digitorum communis, extensor carpi ulnaris. You could use your thumb or your fingertips. Find a point, he gets a twitch reaction, use some gentle extension of the wrist, supination, and then holding. So it's easy enough to do on yourself if you want to just take a minute. I'm just going to put that on hold. So feel on your own arm, check out the muscles there. So if you keep your arm in that position where you're looking at the lateral aspect of the arm, which is the radial side, and palpate from the radial styloid process, work your way up, check out those wrist and finger extensors from the ulna to the radius. So you have that whole extensor muscle mass. When you find the trigger point, you can check and say, oh, let's see, how is that from 0 to 10? Oh, that's a 3. And rest your arm on something. I'm just going to hold my hand up like this here for you, but you want your arm resting. Use your other arm, and I teach patients how to do this. Extend, supinate, extend the fingers, the wrist, and supinate. That'll shorten all those muscles at once. And then hold that for about 1.5 to 2 minutes. Why is it 1.5 to 2 minutes? It's been clinically documented for over, let's see, 60 years now, 70 years, long time, going back to Jones, Dr. Lawrence Jones, strain counter strain. Started doing this work on patients years ago and documented it. And it seems that that's a typical frequency or timing of the fascia is about 1.5 for the connective tissue to change and shift its tension. You're just holding that position fully supported for that 1.5 or so, and then try it on yourself. The key is come out of it slowly. If you move too quickly, you will elicit the muscle spindle stretch reflex response to make it contract again. Come out of it slowly, and then just have the person, if it's just you or your patient, gently move. Gently, nothing sudden, just slow, and just see how that feels, because the muscle has to be re-educated to know it's safe to move now. And that's how I explain this to people. I'm going to move your body in a way that I'm reducing some of the tenderness in the muscles that are sore, but telling your body it's safe to let go now. Literally, we're letting go of the reflexes that are holding the tension. Now, if they just go in and start doing heavy weights and, abrupt things, you're going to undo it. So I like to do some very gentle exercise afterwards, but nothing really heavy duty, because it tends to basically pull that trigger point right back up again. And that's also why I like to teach patients how to do this on themselves. So how about the hamstrings? How many people have those tight hamstrings, trigger points in the hamstrings? So think about the hamstrings, of course, going from the ischial tuberosity down to the tib fib there. So semitendinosis, biceps femoris, lateral, short head, going to the fibula head, semimembranosus, wrapping around posterior medial tibia, biceps, long head. So we've got a couple different areas. You're going to take a look at releasing the hamstring. Calling it semimembranosus,
Now
but it
for the
works for all the hamstrings.
We're going to be palpating here, and let's identify the origin and insertion so we know what muscles. There's 3 major hamstring muscles. The common origin is the ischial tuberosity. If you come down medially to the medial, I'm just going to bend your knee a little here, medial to the knee joint, passing the medial knee, anteromedial proximal tibia is the pes anserine tendon, right? It's a common tendon that has 3 muscles. In this case, semitendinosus is a hamstring that attaches here, but you also have the sartorius and the gracilis, which are not hamstrings, right? Okay, so let's just see. I wonder if he has any tenderness medially. Any tenderness in here? Okay, so he's good with that. Let's follow that semitendinosus up. If we come to the posterior medial proximal tibia, just below the knee joint, you're going to have the attachment of the semimembranosus. Okay, the other medial hamstring. Any tenderness here? And then follow those tendons up. You could feel them if you just bend his knee a little and he tightens up. You could feel those tendons. I'm going to follow the tendons up and see. Sometimes the trigger point's in the muscle belly. Sometimes it's in the tendon, and I'll follow it up. Frequently, I find a big trigger point right in the middle of the posterior thigh. Let's now check the lateral hamstrings. That's going to be the biceps. Again, same origin, but the short head of the biceps come to the posterior lateral proximal tibia. The long head of the biceps comes to the lateral knee, just at that fibula head.
So for the hamstring, basically that's muscle that flexes the knee but also extends the hip. So if you combine knee flexion with hip extension, get a good release of the hamstrings. If you internally rotate the tibia a little bit, you get more medial hamstring release. If you laterally rotate the tibia a little bit, you get a little bit more lateral, biceps release. Of course, you're talking like 5 degrees. It's a tiny, tiny nuance. How do I know? As I'm moving the patient, I ask, well, how does it feel now? Test the trigger point. Oh, that's a 5. How does it feel now? Test the trigger point. Oh, it's down to a 3. How does it feel now? Oh, it's back up to a 6. Okay, how does it feel now? Oh, that's down to a 2. So sometimes you have to reposition a little bit, and it might only be a couple degrees. It makes a difference. So here's one of my favorites, the psoas. And I do this on myself. I find it's one of the shotgun techniques to use on a patient that works great if the psoas is part of their back pain, which I find most of the time it is. So psoas muscles are unique in that they attach, going from the lumbar vertebrae, okay, into vertebral discs as well. They attach directly to the discs. So psoas, it meets the iliacus, it lines the internal wall of the pelvis, and the two muscles come down into a little conjoined tendon that wraps around the lesser trochanter of the femur. So it's a hip flexor, of course, but if the foot is on the ground, what's it going to do? Right? It's going to shift the pelvis, give you an anterior tilt of the pelvis. So it's a very busy muscle, and it's part of our stability. Let's take a look at a video on how to release one of my favorite trigger points. Dr. Jones called it the iliacus, but it's really the iliacus psoas.
The iliacus is a hip flexor muscle, and according to Dr. Jones, the tender point for iliacus is located in the lower abdominal region, halfway between the umbilicus and the anterior superior iliac spine. So palpate, where is that bump right above where his hip flexes? Anterior superior iliac spine, or ASIS. Here it is. So if you took a halfway point between these two, right in the abdominal region, and point directly into the spine. I like to use where the tendon trigger point is. Come inferior and just medial to it, right over that inguinal ligament, you can palpate the iliopsoas tendon. So say he had some pain here, it was a 6, we would want to passively flex the hip. So just cradle his leg, just bending your knee up toward your chest. So I might want to do a little more flexion, maybe add a little lateral rotation, and see how is it now. Oh, that made it go away. It's a 0 now. Excellent. And then we'll hold this. Most of these iliopsoas trigger points take more than 90 seconds to release. We'll pretend that that's completely gone. Let it go in slow motion, all the way down. And then, of course, you test again. How is it now? So the palpation is just to test. We don't keep poking.
And now just something to remember, if you're doing the iliacus, this just shows you if you want to do 2 at the same time. I brought the picture back for you. It's easy for a patient to do this at home. How could you imagine that someone could do their own hip flexor release at home or at work? What position could they put themselves in? So just want to see on the chat, little pop quiz question to see if you're paying attention. So go ahead and see if you could figure that out. What position? Say I'm your patient and my psoas is really sensitive and tender. Remember, when you're palpating to test this, some people will jump clear off the table and you don't realize how sensitive they are. Oh, look at that. Norma's got that flexion and sitting. Lynn, hook line, very much so. So I'll tell them, look, you're in your office, your back is really killing you. You can't really go home and lay down. So go lay on the floor, put your feet up on the office chair. Put them in like a 90-90 position is very helpful, or flexion and sitting. Where you are right now, palpate your own psoas. So feel your ASIS. Put your fingers a little, that's anterior superior iliac spine, the 2 bumps in front above your hips, hip joints. Put your fingers a little bit medial and inferior to the ASIS. And if you flex your hip a little, you'll feel the tendon jumping as you do that. Give it a number from 0 to 10. How sensitive is that tendon if it is? So say, we'll make it up. Oh, it's a 5. How can you release it? What can you do at your desk without even having to get out of your chair? What could you do? You could, flex your trunk on your hip. You don't have to flex your hip on your trunk. Or what else could you do? You could just pull your knee up to your chest, rest your foot on the chair, and just hug that knee. Maybe it's that left side. I could just hug that up on one side, right? So these are things that people could do for themselves. How do you know someone has this problem? When I'm interviewing a patient and I ask them what makes it better, what makes it worse, and they're saying, oh, when I'm out, I'm standing in the line shopping, and I just can't stand in that line. My back is killing me. They can't stand still for any period of time. They can't lay flat for any period of time. That's like screaming psoas at you. What do? I tell the person, well, take your foot and put it up on the shopping cart. You're standing there with your shopping cart. Either bend forward and lean over the shopping cart to release your psoas for 2 minutes, or put your foot up on the shopping cart, put your foot up on a box or a shelf or something and release that psoas, even if it's just one side. Stay there for 1.5 minutes, 2 minutes, and then gently come out of it and move gently. And it'll help you to get through that having to stand in line or whatever they're doing. So yes, Norma says also poor extension and standing. Absolutely. So nice ways to trick that psoas. How about that pain in the butt? Who is it? Oh, no, not who is it. What about treating the pain in the butt? So gluteus maximus. Dr. Jones had a listing and he called all these what he called tender points in the body back in the day. I got to train with him back in like 1992. He was a fabulous, fabulous practitioner. And he had us memorizing all these points and where they're located anatomically. He's like, well, the P3L, the posterior third lumbar, is located 3 centimeters inferior to the iliac crest and 7 centimeters lateral to the PSIS. And we were just like, oh, I got to remember all this. So I sit here with my patients with the book, opening the book and turning the pages. Wait, I got to look this one up. But then I realized it's just the gluteus maximus. So the point could be anywhere in the gluteus maximus. And don't people have different sized buttocks, right? Not everybody is exactly 3 centimeters this way and 7 centimeters that way. So I'm modifying it as positional release in a way that works from a kinesiology standpoint. What does that muscle do for a living? How do we take the strain off of those muscle spindles? We shorten it. And that's essentially what we're doing here. So he called the gluteus max P3L, the posterior third lumbar. Just an interesting, it's not in the lumbar spine, but to him it related to the lumbars. So we'll take a look.
Let's go down into the posterior lumbars. Okay, so we're going to find some points in your hips, and I'm just going to use your left hip as an example. The upper lateral glutes have some tender points, and they're called the posterior lumbar tender points because they have to do with the posterior lumbar muscles. We'll pretend he has a back problem, and he's having some pain or trigger points in the posterior lumbar region, the gluteal region. According to Dr. Jones, the third lumbar point, P3L, posterior third lumbar point, is found by using the iliac crest as a landmark. The third lumbar point is found 3 centimeters inferior to the iliac crest, 7 centimeters lateral to the PSIS, approximately. We'll pretend that he does have a tender spot. Let's say he has, say, an 8 on a scale of 0 to 10, right in this posterior third lumbar. If you're thinking about what muscle is under my fingers, oh, gluteus maximus. The origin of the gluteus maximus, iliac crest, lateral border of the sacrum. It comes inferior lateral to the greater trochanter and the iliotibial band. So it's helpful if you just cradle the leg, hold under the thigh here, and say you get some extension. Okay, let me try adding a little bit of abduction, maybe a little external rotation. Once you're there, this is a good time to get that pillow to support him so that you don't feel like you have to be holding his leg up the whole time. I'm just going to bring him back. If the trigger point was reduced after the 90 seconds, bring him back to neutral, and we'll just look at a different option of positioning. Eddie, lay on your side facing the audience. Imagine if I was extending his hip, and he said, oh, my back is killing me. You put my leg down. It's really hurting my back. So to help that with the back, if you want to keep the back a little flatter, a little bit more comfortable, bend your bottom knee up to your chest. Hold it with your hand. And just keep that steady right there. Comfortable? Mm-hmm. So say I'm on a point here, we'll say that the P3L is on the right side this time. I could easily do my lateral rotation. I want to just pull it up a little bit. There we go. And just rest your leg. I could do just lateral rotation and abduction and still treat the glute without extending the hip. You see how this is just another option. And side lying with the bottom knee bent and hip bent will keep the back a little flatter, a little more of a posterior pelvic tilt, and there's a lot less discomfort for those people with tight hip flexors or back problems, especially the elderly. They're not comfortable on their belly, so try that. The last choice would be supine. I could hang his leg off the table, keep his opposite knee bent. Just an easy way to go.
So that gives you an idea of what to do for the little pain in the butt.
Let's go down into the post.
And just moving back to the next one. This is, if you're thinking about just a quickie on the hip, many people have trouble doing the extension part of the release. because they have really tight hip flexors. So you might want to just do the abduction and or external rotation part of that release, especially if this piriformis might be, remember that's a deep muscle to the glute max. So you want to do more external rotation for that. And, for depending upon how much extension they do have. Okay, so some literature, some research on this. I know we're always so plugged into the research. I mean, that's all you see in the news these days is, oh, medical studies show this or that. We have to go for the science, have to go for the research. Well, I found an interesting quote from Albert Einstein, master scientist, and he says, quote, "If we knew what we were doing, it would not be called research, would it? But we have to go over the research anyhow." So this is integrated neuromuscular inhibition technique as described by Dr. Leon Chatow, effect on trigger points in the upper trap. And that's basically putting together ischemic compression, muscle energy with movement. Ischemic compression, muscle energy with movement, sometimes a myofascial aspect as well. So they said, well, let's take 30 adults who have mechanical neck pain, separate them into two groups. One group gets a hot pack with this integrated neuromuscular inhibition technique. We're going to give them some strengthening stabilization exercise, some work retraining, posture training. Second group got everything, but they didn't get the combination of the ischemic compression, muscle energy, positional release stuff. So they did 6 sessions for 2 weeks, and they found, guess who did better? When you added that combination of ischemic compression, muscle energy, and strain counter strain, the movement, they had a much better response in both the neck disability index, so it's a functional response, pain, and tenderness. So might as well combine it. It's still great to do the strengthening and stabilization, of course, and the retraining, but having that manual therapy really does help. And neuromuscular reeducation. Let me just mention, depending upon how you work, if you're working with insurance, there's all kinds of rules and regulations beyond belief today, and then they cover next to nothing anyway, in my opinion. But what happens is you need to figure out how you're going to bill this. So if you're doing massage, you're probably using massage codes for this. But if you're doing PT or OT or athletic training, you want to look and see, well, what am I doing the most of? If I'm doing positioning, I do positional release, I'm moving them through a range of motion to re-educate abnormal muscle spindles that are firing consistently, causing pain, tension, and a lack of function. So moving through a range of motion that goes under therapeutic exercise, 97110, Therex. Someone else will say, oh, I talked to my biller, and they said the Therex code doesn't pay as much for that insurance company as the neuromuscular reeducation code, 97112. So which one we're going to use? 97112. But we're going to document that, yes, we move somebody through a range of motion as part of that positional release, but we did it for the purpose of re-educating abnormal reflex. So we want to inhibit abnormal reflexes. And that's really a matter of how you document and how you bill. So I like to say, well, bill the highest bidder, of course, but do it appropriately and in line with what each of those codes represents, of course. So something you could try on yourself. Do you have any trigger points on yourself? Where is it? What position are you going to employ for the trigger points? So anybody want to throw a trigger point muscle or muscle group out there on the chat? We got 20 minutes to go, and just make sure you're all awake. I know it's late for some of you, and just show us what muscle has a trigger point. What if it's the gastroc? What are you going to do for the gastroc? Oh, I see. Oh, diaphragm. Norma, got to come up with a tough one. Diaphragm. So where in the diaphragm? If you're palpating the diaphragm underneath the ribs anteriorly, typically the muscles in the front of the body are flexors. So try flexing for that trigger point. If it's more on one side in the front, flexing with side bending toward that side. Rhomboid, great one, Arlene. So rhomboid, what do the rhomboids do for a living? They adduct and downwardly rotate the scapula. So that's hard to do on yourself because then you're holding it. The trick is this fails if the person is holding their tension. If they're holding their muscle and working actively, it doesn't work well. They need to be relaxed. So if I want to adduct and downwardly rotate my scapula, if I put, say it's my right rhomboid, if I put my right arm, you can try this in your chair if you like, and palpate that rhomboid. Oh, there's a point. Put that arm behind your back and lean on it. So now I don't have to hold it because I'm leaning on my arm. I have a pillow behind me too. I have a beautiful lumbar pillow there. And I'm just leaning my arm. So that'll release the rhomboid on that side. So nice thing to do. Okay, so different things. We're going to be moving on. Muscle energy, PNF, whatever you like to call it. Now, the traditional Fred Mitchell or osteopathic muscle energy involves stuff like you see in the picture where you had to identify exactly which vertebral level was moving where. Is one stuck in flexion, side bending right and rotated left? And do you want to extend it, side bend left and rotate right? And then this is all this business that goes with it. And I have muscle energy courses on that as well. But for this, we're going to keep it super simple and look at the post-isometric relaxation component, or the hold relax component of PNF muscle energy. So it's a neuromuscular re-education technique. It also involves moving through the range of motion and muscle contraction, so it can also fit in with that therapeutic exercise code or neuromuscular re-education code. And this is, again, using reflexes to trick the body into what we want it to do. Muscles too tight, holding a trigger point. We want to use that post-isometric inhibition style of muscle energy, because after an isometric contraction, if a muscle is just holding an isometric contraction against a light resistance from the operator, the therapist, the muscle, after it lets go, will stretch more readily because it's in a latency period. So on EMGs, they stick the needles in the muscle and measure the electrical activity of the muscle. That's the EMG. If you take the muscle that's in a spasm, with the EMG in, you find that it's hyperactive. Have them do an isometric contraction just without moving. So it's an isometric contraction against very, very light resistance, like ounces. They could even just imagine contracting, it'll still work. You don't have to use heavy-handed resistance for the contraction. After it releases that contraction, it goes into a refractory period where it takes several seconds, usually 15 to 30 seconds, to relax and allow all of the physiological processes that cause a contraction to be undone before it could contract again. So the calcium has to be pumped out of the T-tubules as an active process using oxygen. All the acetylcholine has to be eaten up by acetylcholine esterase. Remember all that stuff that went on? Well, that's called the refractory period. So it's perfect time to stretch. It takes about 15 to 30 seconds for that refractory period to pass based on the latency period measured on EMG studies. And hey, isn't that a perfect window of opportunity for us to go in and stretch? And much research shows that a 30-second stretch is quite an effective duration of time to improve mobility. So just in general, I just gave you kind of a protocol or a cheat sheet here. State what's limited. In this case, they have tight hip flexors, right? So hip extension is limited. It's only 5 degrees. It should be 30. What muscles are short? Oh, that psoas is screaming, the rectus, the tensor fasciae lata, pectineus, adductor brevis, sartorius. So you can name those muscles. They might hold the trigger points. They're short. You're going to contract those short muscles, the tight ones. We don't always say tight because sometimes when you say tight, people get confused. So we say contract the short muscles, hold it for 3 seconds, very gently. As they relax, then you can start stretching. You'll find you can extend beyond the barrier and usually hold that, a good 30 seconds. 3 to 5 reps should get you a nice measurable increase in flexibility. So they found that using MET or compression versus control for trigger points, here's a randomized clinical trial that compared the muscle energy versus just a manual pressure release versus a control that got nothing in 45 ladies with neck pain, full of trigger points. They checked the pressure pain threshold, neck disability index, a mobility and pain scale on day 1, day 5, 10, and 15. And they found that both the compression pressure releases and muscle energy were equally effective in improving the function and the mobility. So let's take a look how we could do this for the neck. Now, if you're working on getting some increased mobility for scapular depression, scapular retraction, moving into some functional activities for more normal shoulder motion, getting that scap out of its protracted forward position, get into that scapular depression, retraction, and as you're holding for the myofascial release, you can add some muscle energy or PNF techniques, some hold relax techniques. So I'm going to ask you to lift that shoulder blade up just a tiny bit into my hand. Toward me, toward my face. Good, good, good. Just a little bit of pressure. Hold it, 2, 3, and relax. And just breathe as we stretch a little bit more. This little hold relax lets us stretch you a little bit more easily. And then go ahead and hold that for a good 15 to 30 seconds I'm getting the hold position from some of the literature that shows the latency period post-contraction for an isometric contraction is about 15 to 30 seconds based on EMG studies. So that's a great time, little window of opportunity for you to get in and stretch and hold. And then after that time, lift up again into my hand a little bit, hold it 1, 2, 3, and relax. And stretch some more. And again, holding that for 15 to 30 seconds. I'll typically do about 3 to 5 reps of this hold, relax, PNF, muscle energy, depending on the profession. They have a different name for it, trying to get that scalp down into its neutral, normal position. Okay, another study looking at 2 groups of adults using muscle energy or positional release to the hamstrings. Found out that both help improve active knee extension and straight leg raise, but the muscle energy group improved more significantly. Let's take a look at the low back.
Now, we're going to work on someone who has restricted spinal lateral flexion. Commonly, patients present to you and they have one side of their back is really aggravated, tight. Maybe they lifted a box by twisting and lifting, of course, the wrong way. Bending and twisting is one of the most common mechanisms for spinal injury to the low back. Muscle injury, disc damage, you want to make sure people don't flex, bend, and twist, especially when lifting a load. So they might have pulled out quadratus lumborum, lower lumbar erector spinal muscles, and they become in a spasm. You might see that person tends to be side bent to one side if they're really tight. And if they're tight on the right, what motion would be limited? Side bending to the left. So we'll just use as an example the left quadratus lumborum. So let's have you lay on your right side facing the front of the room. So if the left QL is tight, you may recall that the quadratus lumborum is the most lateral muscle, just lateral to the erectors. It comes from the lower ribs and transverse process of L5, sometimes L4, comes down diagonally to the iliac crest. It's a short muscle. It is a spinal extensor and a lateral flexor. It also, if the back is held still, can elevate the ilium on that side. We would say hip hiking or elevating the pelvis. This muscle is very active to help us standing with our standing balance, especially when we're walking. So it tends to become very much in a contracture with people with chronic back pain, or people who do a great deal of lifting, bending, twisting activity. I also see it commonly in long-distance runners, and the constant pounding and absorbing that impact. So quadratus lumborum is most easy to palpate. If you palpate the iliac crest, come into the narrowest part of the waist, push medial inferior, you'll feel the iliac crest, come around, and it's pretty soft by the abdominals, and then as you come into the QL, you'll feel a little taut band right in there. Sometimes people will jump because they often have a hot active trigger point in that area. So I can ask, oh, how much does that hurt when I poked at this point? And say he says, oh, gee, that's an 8. That's really sore. I didn't know that was so sore in there. What would we do first if we tried to stretch this on range of motion testing and he complained, that hurts to stretch? Do I want to jump into that muscle with muscle energy stretching? He hurts. What could we do first? Positional release, strain, counter strain. How could we positional release this hip hiker, extensor, lateral flexor? Hip hike them, extend them, laterally flex them. So we'll use a few pillows for that. In the clinic, you should have pillows and bolsters. So I could take a few pillows. And Eddie, I'm going to ask you to put a bunch of pillows under your shoulder. Just sit up a little bit for me. I'm going to put a whole bunch under there. Okay? And just rest on those. And you see that I already have him laterally flexed a bit to the left. If you wanted him laterally flexed more pillows. In my office, I have tables that bend and move mechanically, so I could just bend up the feet of the table to side bend them, or you could put some pillows under his legs to side bend them. To get more counter strain, again, we're first looking to release the trigger point that we have in here. I can ask him, bend up your knees. Good. To get him to have a little bit of extension, just tip your shoulder back a little. You could let your elbow bend. Just tip that shoulder back. Can you see that he could extend back against that muscle just by tipping back on one side? Check again, how did that work for the trigger point? Oh, it's better, but it's not gone. It's down to a 2, but I still feel it. Lastly, I could do passive hip hiking, and that would be from the ischial tuberosity, I push right up through the ilium. That's most easy to do from the other side of the table. I would block your vision So I'm going to go ahead and do it from this side. Okay to push up on your bottom here? I can easily hip hike them. I'm more apt to use my forearm. It's much easier to get in there for my body mechanics, and it saves your hand. And I could feel that soften as I do that. Hold that positional release for the 90 seconds. Take him out of it. Just relax there. Now he should be less sensitive. Oh, feels much better. Good, let's stretch it. Now you're ready for stretch. We've calmed down the muscle spindle. To stretch it, I need you to sit up for a minute. And we're going to give you a nice stretch to this side of the back by leaning you over a tower of pillows. How does that sound? Okay. So I need you to kind of boost yourself up on those pillows. Good, legs up. So he could side bend over the pillows. See how he goes into a little more of a stretch? I could add some stretch to that area. Feel some pulling in here now? Yeah. Okay. And this is where we could do the contract, relax muscle energy. Hike the hip up against some resistance. Have my hand in the iliac crest, the other stabilizing the ribs. Feel my hand here pushing you down? Mm-hmm. Pull back up against me, lightly. Good. Make sure he's contracting the right muscles. You could feel him elevating his ilium, and relax. Feel the stretch. Mm-hmm. Hike up again, and relax. Feel the stretch. To get more stretch, we can put this leg down. Bring this arm up overhead. Can you see how that would open up that area more? And it may be helpful from your perspective to get two hands in the iliac crest. Some people are really tight here. I want my body weight behind me. I have one foot in front of another, so I'm in like a lunge position. Use your body weight and drop that ilium down, just leaning in. Feel the difference in the stretch now? Mm-hmm. Pull up. Good, and relax. Nice and easy. Perfect. And then again, 3 to 5 reps of contract, relax on that side. Come back, and then you would check him in standing. What is his lateral flexion like? You should be able to measure increased degrees of lateral flexion, or easy way to measure lateral flexion, from his fingertip to the floor. As his hand slides down his legs, you can measure from his fingertip to the floor how many inches is he from the floor. Should be. Now we're going to.
So that's your lateral flexion, which we addressed it as QL, but it also helps the erectors as well, doesn't it? I'm going to address your question, Arlene, at the end. So here they took 50 people for a randomized clinical trial who have acute low back pain and said, let's do either muscle energy and muscle energy combined with strain counter strain. And they found out that they didn't actually have an added benefit of strain counter strain with this particular group. Interestingly, in a study that I did, we did find an improvement there. Another one with 37 ladies with fibromyalgia, and found out that muscle energy, PNF, increased the strength of their respiratory system and endurance, had better expiratory strength, better pain, fatigue, disability, and neck range of motion. But this was more of like a pilot study. So we always need bigger sample sizes and all that good stuff. Another one of combining these techniques together for trigger points, muscle energy with ischemic compression. For people with neck pain, chronic mechanical neck pain, they said, let's do a neck patients plan with exercise and muscle energy and ischemic compression. And the second group got just exercise alone. And they looked at strength and endurance of their neck flexors before, during, and after the treatment. And they even followed them 6 months later, which is really great. You don't usually see the follow-up like that. They found both groups improved significantly, but they had better improvement in the craniocervical flexion test, which is that deep cervical neck flexor test, and better improvement in strength with the added muscle energy and ischemic compression with exercise. So giving people just exercise may not be enough. Let's take a look at muscle energy for the shoulder. We're looking to increase internal and external rotation of the shoulder. So for a patient with frozen shoulder, to release it, bring them into abduction. Now, as you abduct, of course, you're going to find that they have that sticky spot where they have the pain and the restriction. Bring them just a little bit below that level, so they feel the stretch but not the pain. And I like to get them to feel where the limitation is. So take a look over here as I'm moving your arm. So you can wake up now, because patients often fall asleep until they get to hit their restriction, and then you have to peel them off the ceiling. So watch to see how far your arm goes. So Say you go back there, it's like, oh, that's hurting right there, it's too tight. So we're going to put you at the level where you have your restriction or the tension, and I'm going to ask you to push against me in this direction, very lightly, like an ounce or two. So ready, there's the end of the motion. Pull into my hand very lightly, hold it, 2, 3, and relax. And I'm going to stretch you beyond that a little bit farther. And I know it feels some tension, so we're pretending that this client has a frozen shoulder here. So I'm going to pull into my thumb again, hold it, 2, 3, and relax. So we're doing a little bit of hold, relax, muscle energy, PNF, come down into the new range of motion, and hold and stretch. With this hand, make sure that you're stabilizing the scapula, and also humeral head tends to translate anteriorly, so you want to have a posterior glide of that humeral head and a little depression, retraction of the scapula. I could accomplish that by using the palm of my hand to just conform right to that humeral head, wrap my fingers around the acromion, keep that scap neutral, because so many people have the scaps protracting, elevating. So have the scap neutral while you're doing this. Pull up into my hand, hold it, 1, 2, 3. So a couple seconds of hold, very light resistance for the muscle energy, and then release. And as that isometric contraction releases, we're using the latency period where the muscles have to relax a bit to get a nice increase in the range of motion. Okay, and lastly, some gastroc.
Grasp the calcaneus, have the ball of his foot against your forearm, and you can get a nice little stretch. Feel that pull going up the back of your leg? Comfortable? Tolerable. Okay, so it's a good stretch. So you want to get that at least 20 degrees of dorsiflexion. Now I'll sneak up, start adding a straight leg raise, and we'll start to stretch the gastroc where it crosses the knee as well as the ankle. Tell me if it's too much. He doesn't have quite as happy a face on at this time, but he's being a good sport. Now, where would I do my contract, relax? Push the ball of the foot down on my arm like you're pumping a gas pedal. Perfect. Push, hold it, 1, 2, 3, relax. Good, and more stretch. Now, he could do 2 at once. Push your toes against my arm, push down the gas pedal, at the same time push your leg down to the table. Down that way, good. Tighten, hold it, 1, 2, 3, and relax. Good. How are we doing there? Good. Nice work, okay? So let's do the straight leg raise test again and see how the motion is. So ankle and knee, straight, any better? And for you, Eddie? Okay, now take a look at the other leg on the other side. As he comes up here, what's happening there? Yeah, if you start to see that other leg coming up, you have to keep it down. His hip flexors might be tight on that side, which leads us into the hip flexor stretch.
Okay, so that finishes our videos, and just something to think about is if you have a stiff muscle on yourself and you want to try some of these muscle energy techniques, definitely give it a shot. We have lots of ways to reduce our trigger points. Of course, wouldn't prevention be one of the best ways to do that? Oh, I hurt my back lifting up a refrigerator, he said. So, well, then maybe you should have got a hand truck, that kind of thing. So prevention, things like pre-participation screening for ergonomics, sports, physical activities, making sure people learn good stress management techniques and movement techniques, sports coaching to have appropriate technique, and then of course accident prevention is always great. So they did a posture correction for people with neck trigger points and found out that for pain and neck disability, using that combination of muscle energy, ischemic compression alone versus adding cervical traction and posture training, it worked better to include the cervical traction and posture training. Cold spray and stretch, our very last thing. Travell and Simons looked at using a vapocoolant spray, and they say, okay, if that muscle is tight, say the upper traps is tight, we're going to spray it with the cold spray several times, like 2 or 3 sweeps across the muscle, origin to insertion, and then follow it with a stretch. Well, some people discovered that some of the vapocoolants were destroying the ozone layer and decided, let's just use ice stroking. So I was doing ice stroking with a ice cube and then following it with a stretch. Anything that acts as a counter irritant and gives a different input to gate some of the pain makes it a lot easier to do a stretch. So it's just a little extra bonus I wanted to just throw in there. This is just an example of where you might do some of the vapocoolant spray for the cervical spine. some strokes, flex and side bend, in this case to the right, to stretch, and very gently, again, holding it for that 30 seconds or so. So anyone ever try spray and stretch? Anyone still doing that, like doing that? It's just touching on that quickly. So your turn to create some raving fans out of your patients and clients, help increase some of the evidence, contribute to studies if you can, and make this stuff work. So any specific questions you have, Arlene, your question about the Q link, because it's a product, I'd have to address that after the webinar. Many questions or comments, now is the time to go ahead and post them. And is there anything that you folks are going to do differently as a result of spending this evening with us? Go ahead and share that on the chat. Anything that you think is a special technique that we'd like to learn more about later for relieving trigger points, please just post it on the chat. And if you want to actually get back to live workshops, I do that, bring the workshop right to your place. So contact me at my website. Here's one of my classes, having a great time. And you like to positional release, thank you so much. Lots of references, I could bore you reading them. You got permission for some of those beautiful anatomy pictures from Primal. There's your course description if you need it. And if you want more information free, I've got over 80 videos on my YouTube channel. Please subscribe there, check them out, let us know what you think. And if you want to have that hands-on clinical coaching or bring a seminar to your clinic, let me know. Be happy to do that for you. And it's a great time. So breakthrough is a moment in time when the impossible becomes possible. So if you like coaching, contact me. Join a mastermind. If you don't want to do it with me, form your own mastermind. Get some clinicians together and share, because it's really, really great. Put your goals together, design a plan of action, brainstorm, get results that make a difference. And just while I just mentioned, I recorded this and this should be available to you through Zoom. Stay and do the survey at the end. You need to do the survey or course evaluation at the end of the Zoom in order to get a course certificate. I will send those course certificates out to your email over the weekend. So look for that over the weekend, look for it in your spam. But if you already got my Zoom link, which you should have, you'll be able to get that certificate. Any problem, contact me at my website at edusize.com, and I'll be happy to get that information out to you. So comments or questions are most appreciated. And thank you for spending this evening with you. I am the clinical strategist. I'm Dr. Teresa Schmidt, and I'm practicing now in New England. But of course, if you need to telemedicine, have a conference, or just want to chat about your practice, I'd be happy to visit me at my website. You also have my phone number in there, which is 877-281-3382. You can get that right through my website if you didn't have a chance to write it down. And the only source of knowledge is the experience. So get out and try some of these techniques. Thank you for your beautiful comments. Thanks, Jen, Matt. Appreciate your being here, Lorraine. And if you have any other questions, I'll just type my phone number in on here. It's my office number. It's toll free. So feel free to, if you really have to talk live, I'd be happy to do that with you. So share this information. Thank you very much. If for some reason you can't do the review tonight, I can email you a course evaluation to complete and a certificate, and it's worth 2 credits from the National Certification Board of Therapeutic Massage and Bodywork and the New York State Board of Massage Therapy. All other professions, you could submit that certificate, see how you do with that. But enjoy using the work. Good night, everyone. Bless you. Stay healthy. Be happy. Give you a minute if you have any other questions or comments. Thank you. Good night. So the polls were launched. For some reason, it doesn't look like anybody actually completed them. So I'm not sure if that's working exactly right. I will email the polling to you, because it doesn't seem that the Zoom is cooperating at the moment. I don't know if you see it on your end. Oh, you did get it? Okay. It looks like it's not present here, but you can see the questions. Oh, you did get it. Thank you for letting me know, because on my screen it shows that you didn't get it. So there's a couple of questions. See, agree, you liked it, you disagree, you didn't like it. Let us know exactly how you feel. There's 10 questions. I appreciate your filling them out, even if you're not looking for credits. It's always great to have some good information. So thank you guys. Good night and enjoy doing this work. Thank you for being there for people to make their lives better. While you're answering the polls, I'll just mention a commercial message from me. I'm sponsoring tonight's webinar myself, but I am having a webinar tomorrow from 10 a.m. to noon on myofascial release. It's 3 hours, 3 credit hours, 2 hours of actual talking, 3 credit hours. If you're interested in that, just email me and I'll send you the information on that. And I'll be doing lots more webinars coming up with multiple companies. So check them out. Have your company sponsor one. Follow lots of good people out there to learn from. And I certainly am very grateful to all of those who have guided me along the way. Thank you and good night. So that completes our webinar for this evening. If you are taking this as a home study later and you have any questions, use the same email and phone number, and I'll be happy to process your surveys and certificates, which will be done online. Thank you for joining me, and I hope to meet you in person at a future workshop. Thanks for being here. Good night.